Hello everybody, greetings from Healthcare Foundation of India. I'm Dr. K.K. Agarwal. Welcome to Medtalks with Dr. K.K. Agarwal, 7 p.m. show on a daily basis, non-stop 285th edition and 2418th edition. Let's have the headlines of the day. A PIL has been filed in Bombay High Court challenging the different rates for COVID-19 vaccines for the center and state governments and requesting direction to Serum Institute of India and Bharat Biotech to sell their vaccine at a uniform rate of rupees 150 per dose. The US Centers for Disease Control and Prevention has not seen a link between heart inflammation and COVID-19 vaccines, said the CDC director. She said the CDC in touch with the US Department of Defense over its investigations of 14 cases of myocarditis among people who were vaccinated through the military health services. The World Health Organization has said that B617 variant of COVID-19 first found in India has been detected in at least 17 countries. Production of liquid medical oxygen has been increased by 36% from the start of the month and is now just short of 9,000 tons a day, with almost the entire output allocated for medical purposes, barring a small amount set for pharma sector, units making vials and ampoules, and defense establishments. Some painkillers like ibuprofen are found to worsen COVID-19, known to be harmful to heart failure patients and may risk of kidney damage. The ICMR said it is advising against non-steroidal anti-inflammatory drugs and recommended taking paracetamol if needed during the disease. I will be introducing the subject of the day and the speaker once she. The topic is going to be the South African pattern happening, but before that, let's wash our hands. S for Seedha, O for Ulta, M for Muthi, A for Angutha, N for Nakhun, and K for Kalai. Once we have done that, we are now ready to introduce our guest, Dr. Angeline Potze. She is the national chairperson of South African Medical Association. She qualified as a family practitioner in 1985 and is now a full-time practitioner, member of Ministerial Advisory Committee on COVID vaccine and long-haul COVID, recipient of Clinical Excellence Award 2020 by Discovery Health. Thank you, Angelique. I'd like to listen to you for the first 15-20 minutes about the situation in South Africa, and then we will interact.
Thank you so much. Good afternoon to all the viewers out there. I must apologize, I'm on my cell phone. We've got connectivity problems. I'm not used to do this on a cell phone, so please bear with me on this. From South Africa's side, as everyone knows, we started with our second wave beginning of December, and it continued till around about February. We currently are seeing a decline in numbers, but again, it's important to understand that up until today, we haven't seen one day where there was 0 new cases. So we keep on seeing new cases. The average is around about 1,000 per day. Our death rate is a bit better. It's less than 100 per day. So our problem started with our specific variant, the 501Y.V2 variant that is unique to South Africa and at this stage has spread to more than 60 countries in the world. Although this variant is not as potent as the one from Britain, it is unfortunately a very fast spreader, and we had difficulties during December to contain the virus as well as to treat the patients. It was very, very difficult. We didn't have enough oxygen And also we run, as in every other country around the world, we run on skeleton staff. It's the festive season. So we really struggled during December. We went into stricter lockdown, and I think the lockdown, as well as we kept on trying to emphasize the mantra out there of wearing the masks, the social distancing, the ventilation. For us, the ventilation in South Africa is extremely important. We have a very big, nice, open country. And if we can get the people to stay outdoors as much as possible, that also brings down their possibility of either getting the virus or spreading the virus. But it's not easy, as again, in South Africa, the public transport is mostly taxis, and a lot of people during the festive season will make use of these taxis going from one province to another province, and thereby definitely taking the virus with and spreading it. So we also, our scientists did a lot of genome testing around about October, November, when they then picked up this fast-spreading variant. So as everyone also knows, South Africa is currently, a lot of countries doesn't allow South Africans into their country as for fear of the second variant that we have seen, the V2. But important, we still allow other countries. And yes, for South Africa currently, the four countries, and the four we know, including India, because we think that's a new variant that may be part of all the problems that you are experiencing in India, with the Brazilian, with the UK, and the South African. Those four variants, I think, would be prudent to watch going forward, as we simply cannot afford losing healthcare workers. Doesn't matter which country it is. And again, it's not only in the end of the day the healthcare workers, but the patients as well. So then South Africa, we struggled with the vaccines. There was lots of reasons for that. But we finally managed, with the help of Professor Glinda Gray, under the Sisonke implementation study, to get vaccines in. Around about 500,000 vaccines came into the country beginning at the end of February, beginning of March, where we tried to vaccinate our healthcare workers. That's only a program for healthcare workers. So we, again, because all of these vaccines didn't come in at one time in one batch, but it came in on a weekly basis, 40,000 or 80,000. We currently received the last of the 500,000, the still outstanding 200,000. When we received that, unfortunately, with the Johnson & Johnson, the rare clotting disease that was picked up in United States, our program also stopped. And we were looking at what is happening in the United States, as well as what our own data is telling us. Although there has been, the government estimated 1.2 million healthcare workers. This includes support staff, anyone else working in a healthcare facility. It seems that they had bring down that number to about 1 million. But again, when the rollout under the Sisonke project stopped 2 weeks ago, up till then, we only had 300,000 healthcare workers that is front-facing. We started first with healthcare workers that's patient-facing, front-facing, face-to-face, to try to protect them as much as possible. It takes about 28 days for the vaccine to give you enough immunity. Then, as I said, the Johnson & Johnson rollout stopped, and it only commenced today. So we are extremely happy that it commenced. Now we still have 200,000 vaccines left. that we will give to these healthcare workers. And only then, after the 500,000 vaccines has been used, will our first rollout, actually official rollout, starts. That is where the National Department of Health got the vaccines paid for and coming into the country. In South Africa, the studies was quite clear and showed us that Johnson & Johnson, during December, when we had our second wave, incidentally, Johnson & Johnson was being tested in South Africa, and it showed very, very good data against our current variant. We are speaking about trying to get people out of hospital, so we are saying very good data against severe disease. From there, also Pfizer, we believe Pfizer will also protect our people against severe disease. And although we haven't started with any Pfizer rollout in South Africa, we presume it will start in the middle of next month. It might be difficult. We are quite a hot, warm country, and there's a lot of logistics around the Pfizer vaccine, as well as having 2 jabs with the Pfizer vaccine. We're not sure how many people will come back for the second vaccine, but we hope, and we are trying to run public campaigns around that. There was a lot of questions around ivermectin, the use of ivermectin in South Africa. SAHPRA did, and in the end, give a preliminary under Section 21 permission to use it, but we need the studies. So there's a lot of anecdotal study or going around telling how good ivermectin is working, but we need the studies. Unfortunately, it's very difficult because we don't know what dosages are being used, how is it used by the different practitioners, especially at a preventative level. So for now, that's one thing that we're not sure about, but it has been, as I've said, approved. Then the only thing that we really oxygen, and then you need to get your patients to, especially with comorbidities, the patients above 60 years, to be adherent to their chronic treatment. Now again, and I think it's a problem in other countries as well, the moment when we started with lockdown and when the whole thing about COVID-19 and the pandemic started to gain momentum, a lot of people didn't go for their chronic disease treatment. South Africa has got a high burden of HIV as well as TB. We also noticed that a lot of the children didn't go for their vaccines. So all of that will add another burden onto the South African healthcare system. Very fragile. We have a public and private, more or less 50-50 regarding doctors. I'm not talking about support personnel. And it might be a problem, the fact that we have these 2 systems, because the one system functioning a bit better than the other system. And we also noticed in South Africa, and again, I think it's predominantly in other countries as well, that most of the personnel has not been trained in pandemic treatment. How do you handle a crisis in a pandemic? And how difficult it is just to take nursing staff from one department and throw them into ICU and think that they can be able to cope in the ICUs. They struggle, they can't cope in the ICU. Most of them can't, they're not trained for that. And it's unfair against them as well. So what we also see in South Africa is a lot of what we call PTSD, post-traumatic burnout type of behavior. Again, because we don't have enough healthcare workers, we really struggle with getting healthcare workers that's trained at the right level to do the job at that specific level. Although I must say that if I look at our scientists, I think we've got very good scientists. They are assisting us a lot with genome tracing, with the vaccines, what vaccines, how to look at the vaccines, how to make sure that the vaccines are applicable to our country. And maybe this might be a problem in other countries as well, that one buy a vaccine because it is available and then hasn't done enough testing, whether that vaccine would help against possible other variants coming into your country. Um, for for now, again, we keep on trying every day on a daily basis, try to motivate people to keep their masks on, to do the mantra. It's difficult. It's very difficult. I think people had enough of this. But I think, again, going forward, seeing there's not a lot of medication on the market, we try everything. When you trying to vaccinate people, we're trying to tell them, if there's adverse effects, there's an app that you need to use. Give us that adverse effects. I must say, with the 300,000 vaccinated people under the healthcare professionals, we only received around about 4,000 what we called adverse reactions, and in it mostly around a sore arm, a bit of a fever, a bit of body aches and pains. Nothing really spectacular, saying that this is a proper side effect or adverse reaction as we know it, and from a medical point of view. So difficult to tell a patient, it's not that bad, because remember, every symptom is for a patient 100%. Again, we haven't seen any deaths around the vaccines with Johnson & Johnson. But again, we have only vaccinated 300,000 people. Maybe if we vaccinate more, we will see more side effects. A very good colleague of mine, after being vaccinated, unfortunately, platelets are normal, and otherwise she's normal. It's difficult to prove that this is coming from Johnson & Johnson. We suspect it did, but we cannot prove it. But otherwise, for that, there's not really a lot of severe adverse rare effects, side effects with the clotting that has been seen in other countries. I hope this makes sense, that what I'm trying to say in a very short space of time. KK, you can help me out here. Sylvia, kan nou nie hoor nie. Hey. KK, you are muted.
Yes, am I audible now? Am I audible? Ritu, am I audible?
Yes.
Yes.
Yes,
So first
Yes.
of all, is let me explain to you. There is a term in India called Jugaad, Jugad. Jugaad means how to manage triage. This is called triage OPD. So suppose you want to see 1,000 patients in South Africa and all online. And suppose you want to do a 8 hours OPD. Angelique, are you with me? Suppose you want to do,
Yeah, I'm working.
suppose you want to see 1,000 patients in a day as a single practitioner, and the online services are available. So you call all the people with loss of smell and loss of taste in 1 hour, half an hour session, give them general counseling and a general prescription. You don't have to see them one by one. If you have all the patients who are children less than 12 years, you can handle them. Hundreds of patients can be handled in half an hour. So similarly, you can decide all pregnant and lactating women this half an hour together, and you can give them a joint consultation and a joint counseling. And in a pandemic-like situation, one doctor should be able to see 1,000 patients in a day. That is only possible if they do a joint consultation, counseling, and a joint prescription. And with that, you should be able to manage that. Now, I want to discuss here with you one pattern I want to discuss and share with you. So I want to share some slides. And I want to share that is Now this is, I'm talking about South Africa. I'm talking about South Africa and India. If you see South Africa graph, the Indian graph is different. The South Africa graph and the Indian graph is different because Indian graph shows more steep rise in the cases. Can there be, is it explainable only by, is it explainable only by a different strain? I am only trying to say is the graph in India is in South Africa is more like a mountain, and the Indian graph is more like a Eiffel Tower, black wala, more like an Eiffel Tower. So the graph, second graph in India is not matching the second graph of South Africa. The second graph of India is not matching the graph of Brazil. The second graph of India is not matching the second wave of UK. The second graph of India is not matching the graph of California. So these are the four different strains. Therefore, Indian graph is different. Indian graph is not matching the graph of Pakistan. Indian graph is matching the graph of Bangladesh. Bangladesh also had a high peak. Indian graph is now coming back to and so do you have any comment to make? That means Indian variant is different and we are facing a different graph altogether. So this is a new strain, which is B16617 or 618, whatever it is. Now coming back to 617 is behaving, now coming back to South Africa, how much time would take to come to the peak? How much time it took to reach the peak of the second graph? That's my question. So if I come back here, if I show you the graph, so if I show you the graph, I'm only trying to say is if these graphs are different, so I want to know how much time it took. So therefore, if I say your lowest cases were on November 20th, and the peak was seen in January 6th. So it took 10 days, so it is 1.5 months.
Yeah. It seems like that, yes. Yes, you are correct. And then it gradually went down, but it never went down till zero, you know. And that's still a bit of a concern to me, that there's no single day that we had a COVID-19 free day. Also, remember, and I think it's the same maybe in India, that if you look at the data, the data is dependable on whether those people are tested and what is happening at ground level. So the data that we can say for sure is the data in the private sector of people that's been admitted in ICU. The rest of the data is difficult because this second variant of ours didn't follow the normal pattern that we saw with the first variant during the first wave. So I am very worried that we're actually missing cases that is mild because we cannot test all of them every time they come in. Now, in the South African setup, if you look at testing the PCR test, the question is, will the PCR test pick up the variant that's India currently seeing? That's the one question. The second one is, you have to pay for it in South Africa, and it's 800 Rand. So every time when it's negative, you pay 800 Rand. So you can only go so many times and you run out of money. And it's difficult in this public sector because you're not tested every time when you have an upper respiratory tract infection, not feeling well, and with a bit of loss of smell. So I think the numbers are not a true reflection of what is really happening. And again, if I look at what India is, I'm quite sure that you've got a different variant that is quite fast spreading, but also, if I listen to the media reports, it's not only fast spreading, but also quite you know, makes the people a lot sick. It seems to me that the people are very, very sick. It can be that there's comorbidities
That I will
uncontrolled
come back. I will come back to the Indian situation. But in the meantime, why in Brazil we are seeing a different response? You see the graph in Brazil, because Brazil is another strain, and this it is something like starting from April to April for 1 year. It is not going down. It is showing peak after peak after peak. The problem, this is showing a completely different pattern than other countries.
The question is, are there good lockdown measurements being held and being in place, and are the people wearing their masks and social distancing? So, because that is something that one can measure and that one can implement. That's, I'm not sure what is happening there.
Then I'll go back to UK for a second. So I go back to UK and see the graph in the UK. And UK, if I see the graph, so it showed the second wave never came down, and it started with the third wave. And then here also it came December 5th, and then it came back to January 8th. So it is almost like a peak came in 1 month. The peak came much earlier in the UK strain. Now I come back to the Indian strain, because what is disturbing me is in the Indian strain. Let me come back to the Indian strain. So I go back to the Indian strain. So if I go back to the Indian strain, it never became zero. The minimum number was around 20,000, 15. So it was around, the minimum number was approximately 10,000, whatever you say. So I take it, even if I started from here, see, it is still April 27th, and it started in, when do I say it started? It started somewhere here, that is in February 4th. So it is lasting much longer than other countries. That's what I'm trying to say. The wave it hasn't yet peaked, and it is lasting much longer than other countries. That's only I'm trying to say. That means if this is happening, and WHO today has said that the Indian virus is present in 17 countries, then I'm worried about this strain of 617. I'm only, because 617 is behaving like more like a South African and Brazilian strain, and the 618 strain has deletions, but 617 looks to be more worrisome to me, because the wave, once the wave has started, it is lasting almost 2 months are over. So this is 27th and April, then this is March, then the wave started somewhere here. Even if I take it March and April, 2 months are over, it hasn't gone into the peak. And if that's so, this will be much more contagious than any other available strains except Brazil, because we don't have the correct picture. So therefore, I'm only trying to say is 617 be the concern of the whole world in future? And is it this 617 which is causing younger people? See, I'll show you one more slide which I got. One more slide I want to show you, and that is one more slide. And this slide is comparing This slide is comparing the virulence of various viruses, and this, if this is correct, this is showing the virulence of various viruses. So if you can see here, the most virulent is South African in terms of contagiousness, but it hasn't caused, it is still, but it hasn't caused, it hasn't caused, it is a contagious from the point of view. Then second is Brazilian strain. The second is Brazilian strain. The third is New York B1527. Then comes this Indian strain. And the Indian strain is much more immune invasor than the California state. And then it is much more than B127. It is much more than B127. And that is much more than D614G. So my concern is, if Indian strain is much more than B117, number one, why will it replace UK strain all over the world? And the second is, why South African strain has not been able to become and overtake the B117 UK strain? That's my question.
That's very good questions that you are raising, KK. It is a concern. You know, if you look at again at the Indian graph, although it's you nearly when it was plateaued downwards, and sort of a stable plateau, you had still 10,000 people a day. South Africa, we still see 1,000 a day. So it is still a concern, because somehow in certain countries it still seems that the virus is still lurking there. It doesn't go away totally. And then again, the deletion maybe in the Indian in the strain that you are now seeing, or the variant that you are seeing, maybe that deletion that is escaping the immune system. The question now is, does the vaccines, or do the vaccines, are they able to produce enough antibodies against that strain that is eluding the immune system?
So I want to end by sharing one message from today, which I have learned from you, and that is, it is important to reach zero number, like we have seen in Singapore. So it is not important to leave it some numbers. You must achieve new cases down to zero, less than 12, less than 2, less than 3. That's what it is. And let me see China. And so unless China is, day average is 4, 5, 6. So unless you reach a near zero number, the spots will keep on occurring. Am I correct in my understanding now? So
I fully agree with you.
Unless you reach, let me see, Korea, South Korea. So SOUTH, South Korea. The South Korea, we are seeing a problem because they never reached a zero number significant time. So let me see Hong Kong.
I think they reached a zero number.
So Hong Kong is also showing the pictures because it never reached a zero number for a significant time. Okay, it did reach, but it is showing. So the message for today is that our aim should be to reach as low as possible, and not that we are happy by reducing 90% of the disease. The burden of the disease should be less than 1%, which is equivalent to your positivity rate of a nation. That instead of having a positivity rate of, let's say currently the positivity rate in India is 33% in Delhi. So we should achieve a pan country positivity rate has to be lower than 1% or lower than 2%. And if you have in some state 5%, some state 10%, some state 1%, the disease will come back. Am I correct?
It seems like that if we look at the stats, if we look at what we are seeing, also remember if you see 1,000 a day, remember what I've said, we are missing maybe another 1,000. So there's always, it should always, you should try for really to get 5 patients, because if you then miss, you only miss maybe 5 more. But if you miss 1,000, you miss much more than 1,000 per day.
The figure, the calculation is 1:30, not 1:1. For every 1 positive, you miss 30. So if you are missing 1,000, if you are diagnosing 1,000, you are missing 30,000 more. That's what the statistic. That's what the figures, the Hong Kong figure, China figure, New York figure, Indian figures are. This virus has been, for every positive symptomatic case, there are 30 asymptomatic cases. So that's a nice interaction with you, Angelique.
And that's the problem. That's why we need to get it down to 0.
Yes, absolutely, down to 0. That's a lesson learned for me. Every day I try to learn one message.
Thank you. And I managed to do
as low as possible. Thank you very much. We'll be seeing you on Saturday again. Thank you. And that's all for today.
Bye.
Show her the certificate, Ritu. Yes, she has gone. Send her the certificate. That's all for today. We'll be back tomorrow, 7 p.m. with another show. Keep watching Medtalks with Dr. KK. Namaskar.